My name's Dr. Peter Noël, board certified veterinary radiologist. Thanks for joining me. Episode 9, maybe, of Report Pending. Some of you, I think, are returning. For those of you that are new, I'm a board certified veterinary radiologist, and every Monday, we skipped last Monday for I was traveling for a holiday, but every Monday for the last 9 weeks, we've been meeting to discuss and practice your skills interpreting small animal radiographs. It's important that this is free. It's important that you feel like you're getting value from this opportunity. We've been setting up the format so that you have an opportunity to form an opinion after I present the case, but before I tell you my findings, and then afterwards we have an opportunity to ask some questions. The goal is going to be balancing that with trying to get through as many cases as we can. The more cases you see, the better off you'll be, especially since there's so many variations of normal. A couple of housekeeping things. Workstation setup. It's too late now to do a lot of messing with your workstation, but if you keep the lights dim, about full moon brightness, that's important. And then crank up the brightness on your monitors as high as they'll go. So that'll help you with discerning the different shades of gray. All right, so without further ado, we're going to jump into it. We got a case from Dr. Lucy Curtin. They're in JPEG format, but we've got a case. The history, I don't have the history. Sometimes the history we say is for suckers. So I'm just going to present the case. If Dr. Curtin's on, we can ask her to step in. But I will tell you that it's a cat and they're musculoskeletal rads. So I'm going to give you a minute or so to form an opinion, then tell me kind of what you think, and then I'll tell you what I think, and then we'll go from there. So let me share my screen. All right. So it's a cat, and they've taken these radiographs. There are 2 radiographs. You know, we could presume that they're taking radiographs because he's either lame or maybe the owner's felt something. But here you go. So I'm going to give you maybe a minute or so. All right. Apparently this is easy. Yeah. So this is I would describe this as a malunion fracture. Malunion implying that it's healed but in the wrong position. So it's caudally. It's got a caudal angulation here. You can see that there's a cortical disruption here. So that's the inner cortex, the medial cortex, and then there's the medial cortex. So this is all mineral bridging callus. There's likely involvement of the fibula as well. Dr. Cruz, what's up? That's a new name. Good to have you. Yeah, this is an old fracture. So the red-headed stepchild, I can say this because I don't have a stepchild, but I've got a red-headed son. But we often forget about the soft tissues, right? Everybody's focused on the skeletal, or so the osseous structures of the musculoskeletal system, but you can't forget about the sort of red-headed stepchild, which is the soft tissues. So the soft tissues can really help you decide whether we're dealing with an acute or chronic process. So even if you're like, well, I'm not really sure what's going on here, you can see that, and they are overexposed and they're JPEG, so we can't window and level to get some of that soft tissue coverage back. But you can kind of tell there's no swelling, even with what we have here. So there is chronicity. The next thing you want to do is look at soft tissue coverage and say, like, is the cat lame? And he's a little bit lateral. There's a little bit external rotation of the left pelvic limb, which can make this left pelvic limb musculature look more robust, but the musculature doesn't look too dissimilar. So I guess I wouldn't be surprised if he's not lame on this leg. Maybe he's got an abnormal gait. Maybe the owner's palpate this chronic fracture. But the things that I look for are soft tissue coverage. That's a big one. And so I don't see any asymmetry suggesting that he's probably not lame. There's also mineral opaque callus that's bridging the medial and lateral cortices and also along the caudal cortex. So there's evidence that it's chronic. There's evidence that it's inactive. There's evidence that it's healed. It's healed in the wrong orientation. So we've got a malunion fracture. And this isn't a big deal unless it's creating some abnormality in the tarsocrural joint or in the stifle joint. That's a pinpoint mineral focus. That's a meniscal ossicle. Those are fairly common when I look at rads, even in young cats that don't present with lameness. So that may not be an issue. So kind of a nice case. Starting out when I was a long time ago, like an intern resident, I always thought that every fracture had to be acute and traumatic. So don't forget that there's chronic fractures, there's the varying stages of healing with fractures, but there's also traumatic and pathologic. So we don't really know much about this one other than it's likely from a traumatic fracture. The rest of the skeletal structures look normal. So we don't have any evidence of disuse osteopenia, something like secondary hyperparathyroidism, renal secondary hyperparathyroidism, or some sort of congenital / developmental anomaly like osteogenesis imperfecta. So there's probably a chronic healed malunion fracture of the right fibula and tibia. The distal femur. The distal femur. Is that heterogeneity bugging you? That speckling, the salt and pepper? I think when you have sort of highly contrast radiographs, you'll have that. I don't know if that's what you're looking at, Dr. Allen, but the contralateral limb has some of that speckling as well. So I think it's fine. You can't talk about joint space on a non-weight bearing radiograph, and plus these limbs are foreshortened, so they're probably not fully flat. The knee may be flexed and coming out at you, so you have to be careful. So plus I don't see any OA. The subchondral sclerosis, no evidence of swelling. Yeah, that condyle is probably fine. I'm not worried about it. We got that other condyle right here. Oh, the variations of normal. Okay, let me close these and then hope there's no incriminating data behind it, which there is not. And there's not. Okay, let's party. I had the unfortunate opportunity to erase all of my cases that I had. I did that about an hour before I started, so I scrambled to get some more cases. So I think I got some good ones though. Let's do it. So okay, here we go. We'll start with this one. All right, cranking up the brightness. Here we go. We've got 3 abdominal radiographs. There's a left lateral and 2 VD views. And this is a middle-aged dog that's presented with vomiting and diarrhea and lethargy. Okay, let's do it. Okay, that was a minute. Anybody got any abnormalities or anything that they see that doesn't look right? So when we formulate the radiology report, you may or may not be doing that, but just the process is the first thing I'll do is describe abnormalities and things that are normal. And then the next thing is we'll conclude sort of in a succinct way about the abnormal findings and also pertinent negative findings. And then we'll make some recommendations. I typically stick to imaging recommendations. So one of the things I think, Dr. Allen, so we've got some discussion about the lumbosacral vertebra. The stomach is empty. That's a hard one, right? So the first thing that we want to do, I mean, this person has probably taken the rad because they want to see if the dog's obstructed, right? So we want to know if there's peritoneal gas, pneumoperitoneum. That would be very concerning. And we would, if they haven't had some sort of celiotomy in the last, they say 28 days, but I haven't really seen 28 days post-op for the presence of peritoneal gas. So, okay, couple of things with for those of you that may be new. I go caudal thorax first, right? Left lateral view. You want to make sure that you don't see any pneumonia. Then there's the liver right here. The liver, the gastric axis should be perpendicular to the vertebral column or parallel to the ribs. You also look at the edge, the pointy caudoventral margin that should be sharp. Okay, so this liver is normal. Then I do the spleen. Here's the splenic tail. Looks nice. Looks very nice. Here's the splenic head. It's totally fine. So the spleen is normal. There's no rounding. Then for whatever reason, I jump to the urinary bladder. Now the pelvic limb is pulled cranially. You should pull it caudally, but the area looks fluid opaque. So I would probably just comment that the urinary bladder region appears fluid opaque. The next thing I do is I look at the kidneys. So here's the left kidney. right here. Okay, the right kidney is up here, but it's very common to have a hard time to see the right kidney on the VD view, because it usually, in my experience, a lot of it's superimposed with the GI. The right kidney is hiding up here. Okay, so the cranial margin of the right kidney is effaced with the caudate process of the caudate liver lobe. Both of them are soft tissue, so there's no differential attenuation. Okay, so that all looks good. So then when you pull this pelvic limb cranially, it can kind of make some bunching. That's one of the reasons to pull that thing caudally. So the bunching, you want to pull that pelvic limb caudally and really stretch the dog out. That could be contributing to this patient sort of bunching. The next thing I look at is the stomach. So this stomach is right here, and it is right here, and it's mildly gas filled. It's a left lateral view. I don't really see any sort of abnormal shape in the pylorus on the left lateral view, which would be concerning for a pyloric outflow. If the stomach, usually in a pyloric outflow situation, big bag of fluid. So the next thing after I identify the stomach in the GI tract is the colon, and the colon lives in here, right? So here, here, here. So anything in this region is going to be colon. Okay, so there's descending colon. The colon, I can't follow it. I don't know where it is. I'm not going to lie to you and say that it goes this way. I can't follow it. But the cecum, someone guessed that this is the cecum. The cecum is L25 to the right of midline. Sometimes it can sort of wander toward midline. Occasionally, I've seen it a little bit towards the left midline, but this is 1, 2, 3, 4, 5. So it usually sits right here. So that's the cecum. So then the hardest thing is usually the small intestine, and I describe it as the course, the content, the size, course, and content. So the size, the rest of this is small intestine. And I don't know about you, but nobody really looks huge. Everybody kind of looks the same size. The course. So the course would be sort of corrugation would be the descriptor for like bacon or sort of, it usually when you use that term, you're implying sort of inflammation versus plication is sort of the linear foreign body. But bunching kind of encompasses both of those, I think, which is why I tend to not use it. I either say plicated or corrugated, but if you don't know, and that's okay, but you think it doesn't look normal, you can sort of say they're bunched, because all you're trying to convey is like something looks like they're either anchoring the small intestine or they're being displaced. And so that is just going to take time, I think, to look at these, but these are all kind of making gentle turns. And some of the ways that you can get yourself out of this is the small intestine plicated, is you want to see, are they in different areas of the abdomen? So on the lateral view, they're all kind of just sitting right here. But on the VD view, you've got a loop here, a loop here, you've got a loop here, you've got a gas-filled loop up here. And I don't see a ton up here. So you've got them in the left abdomen, and then you've got them sort of in the right abdomen, and then the caudal abdomen. So on this view, and you could window and level, and you will see that there's some loops here. So sometimes also I'll almost do this, almost like back out and then take this sort of 30,000 foot view and go, does anybody look too big? Does anybody look plicated? Does anybody look like they're containing anything that's abnormal, like a foreign body that's radiolucent or radiopaque? So I would describe this as probable gastroenterocolitis. I feel pretty confident that this dog does not have a mechanical obstruction. I feel good about this sort of bunching not being plication, because when you look in here, like this is making a gentle loop. This is making a gentle loop. These right here, they have nice gentle turns. So everybody's kind of gentle, as opposed to, and we may see plication, which is the linear foreign body. They're very choppy. So I would describe this as there's nothing in the stomach, nothing in the colon. The small intestine is either empty or has a little bit of fluid in it and gas. And so I think this is probably gastroenterocolitis. To Amelia's question and some of the other questions about peritoneal gas, that can be tough, especially when you when you have overexposed radiographs. You're dealing with other, you're not dealing with your machine and the same technique. And so I will have to sometimes suffer through different radiograph setups, different techniques, and it can be a struggle. One of the things that I do for peritoneal gas is I look for the location in the abdomen, and also the shape. So if you're worried, say that this is peritoneal gas, and I don't know, Amelia, if you had a specific spot, but if you're worried that this is peritoneal gas, if it's tubular at all, you got to chill out. Tubular is implying that it's probably within a focus of gut. This is tubular. That's a bit tubular. That's a bit tubular. This is tubular as well. The next thing is the location. If you're seeing gas in areas where you think you could probably have small intestine, then you also got to chill out. So areas where I will look for peritoneal gas are in the gutters over here, but also if you have enough, it will get up in the highest part. It'll get up here in the cranial abdomen. So you'll see it contouring the diaphragm here, and you'll see it sort of oddly shaped, and they're usually angular and so on. So this dog does not have a pneumoperitoneum. This dog does not have a GI obstruction. Ure brought up a good point. The dog does have an abnormality here, which is not uncommon, particularly in German Shepherds. So this lumbar vertebra, the transverse process is anchored to this iliac wing. 1, 2, 3, 4, 5, 6, 7, 8. So this transitional lumbosacral vertebra can result in altered mechanics, biomechanics of the pelvic, of the hip joints, and sometimes result in OA. The included hip joints on this patient don't have evidence of degenerative joint disease. Okay, next case. It's a cat and he's vomiting. It's a younger cat. Been vomiting for 24 hours. All right, anybody got anything? Abnormal findings, pertinent negatives, maybe a diagnosis, maybe the next test, maybe a general question. How confident are you, Dr. Tuber? Like it's definitely obstructed or probably obstructed? Okay, so probably need an ultrasound. Yeah, so, okay. You guys want me to go over the abdomen, or you just want me to show you what I perceive to be abnormal in this patient? Fat kitty, yeah. So this is a young cat, right? So we see the physis right here is open. I also feel like maybe this could be a female. So a little focus of mineral right here between the intra-abdominal urethra and the descending colon, which may be dystrophic mineral. So we may have a fat female younger cat. Okay, and young cats do dumb stuff like eat string. So this small intestine is definitely plicated. And what you'll notice is these margins right here, they just kind of look, my old boss called them momental wedgies. So fat kind of interdigitates in, and then you can kind of see it through here. And then these loops are kind of doing this right here. So this is where I'm looking right here. And I go, that is not normal. That is plication. Okay, so the stomach only has a mild amount of gas, probably a little bit of fluid as well. The colon has formed feces and gas, so we know that it's probably acute. Left kidney, spleen, stomach right here. So this is a small intestinal mechanical obstruction secondary to a linear foreign body. All right. I think linear foreign bodies, the consensus amongst credentialed folks, and maybe it's been your opinion as well, or your experience as well, but it's certainly been my experience that small intestinal mechanical obstruction secondary to linear foreign bodies in cats can be somewhat easy. The same cannot be said for dogs. I feel like dog linear foreign bodies can be a nightmare. They can be really difficult to diagnose. But that right there, burn that into your mind. That sort of this little bunchiness right here, and all right. So somebody brought up something about an ultrasound. Okay, so I'm going to show you some ultrasound clips. See if anybody else has any objections to this. Okay, here we go. Okay, vomiting animal. Okay, so this is the stomach. Okay, anybody got anything? Stefania Cardona Cruz is saying linear foreign body and small intestine plicated. Okay, so this is a linear foreign body. So I thought it'd be cool just to show this one right on the heels of the other one. So one of the things, this is a cat. This is what you'd see if you just threw the ultrasound on it, okay? Stomach full of fluid, like not good. This whole thing is the stomach. Near field has some gas. There's some funk in there sort of settling. This is colon, strongly shadowing feces, strongly shadowing feces. It's important to show that there's some empty small intestine, or maybe there's a little bit of mucus or liquid, but these are mostly empty. So this is a loop right here. Mucosa, better to use a linear probe for some of these cats. So you've got the, for those of you don't know, here's what I'm seeing. So the first thing that I saw is the fat around here, a little more subtle, but the fat around here is hyperechoic. So the mesentery is pissed off. And then there's this structure right here. So I'm looking at this line right here, and it's straight, but yet there's all this small intestine that's hanging out. Like here it is, right here. There it is, right there. Okay, so this is the dental floss. Throw the dental floss, in the toilet, not in the garbage. So this cat is eating something. So this whole bright line right here is the linear foreign body. Okay, so when you see this, go cut the animal. Now, I used to always think that when you saw this, it was doom and gloom. The animal was screwed. They would need a resection and an anastomosis and all that. I have had some of these cases, especially if they're acute, where the surgeon can go in and cut it, and the intestine just sort of cut the foreign body out or disrupt the anchor point, and it sort of releases, and you don't need to necessarily do a resection and anastomosis. So, all right, linear foreign body. Let's see if this is a different case, but let's see. I think it's a different case. Is it a different case? Okay, so this is a fat cat. Just plain, this doesn't look like a linear foreign body to me. You see, compared to the other one, there's a lot of gentle turns. Yes, there. Okay, that's more concerning. This has got the paisley or the curly cues. So this is more concerning on this view. Plus, there's probably some foreign material right here. What's it with fat young cats? Okay. Hard shadowing in the stomach. No, I wouldn't say there's hard shadowing in the stomach. It says dirty shadow. Dirty. So this right here, this comet tail artifact is gas. So I wouldn't, this is colon. I don't know if you mistook Doc Miller colon for the stomach, but this is the stomach. You've got the wall layering of stomach, which admittedly is kind of shitty with this microconvex. But this whole thing is stomach. There's some debris floating in here, which could be foreign, but it's not shadowing. And this is a gas shadow, comet tail artifact. So it's not a gastric foreign body. Would we be surprised if there was something in the stomach anchored to the pylorus if it wasn't anchored under the tongue? I don't know, because it's got to anchor somewhere. And then Dr. Allen was talking about, sacralization, lumbarization. So the transitional lumbosacral vertebra would be sacralization. And then the lumbarization would be one of those ribs decides it's trying to be a transverse process of a lumbar vertebra. That does sound more like the deep portion of thrall. Okay, what do you guys want? You want a 4-year-old male neutered mixed breed Tachypnia, 3 views of the chest. There's a right lateral, a VD, and a left lateral view. All right, I'm going to tell you what I think. You ready? Here we go. First thing I noticed was that the cardiac silhouette is enlarged. Unstructured interstitial dorsal lung field. Dr. Steve is right on it. Hot damn, here it is. He's right. I agree. We'll talk about that in a second. Okay, a lot of people are getting the reverse D thing. So the first thing that I'll tell you about, just quickly about, and I've said this before, about the right-sided cardiomegaly, left-sided cardiomegaly. Now, for every 10 cardiac-related cases, maybe one I think, has true radiographic right-sided cardiomegaly. Some of them will have right and left, but just if you put up a study and I said, close your eyes, and the dog has cardiomegaly, you could just guess that it's got left-sided cardiomegaly, and most of the time you're going to be right. So the incidence, at least that I feel like we see of right-sided cardiomegaly is low. I also think radiography, thoracic radiography, is insensitive for detecting right-sided cardiomegaly. Some of that could be because a lot of the diseases that I feel like I see are a pressure problem. So pulmonary hypertension causes, it's a pressure. The increased pressure causes concentric hypertrophy of the right side of the heart. And if you remember concentric hypertrophy, the wall thickens at the expense of the lumen, so the heart gets bigger sort of internally. And as a result, on the radiograph, it's less noticeable, as opposed to eccentric hypertrophy, the classic case being mitral valve disease. You have a volume problem, and so those lumens dilate, and then it gets really big, and so it's really obvious. So just playing the odds, probably not right-sided cardiomegaly. Now, right-sided cardiomegaly, I'm going to need to bring one of these up. I like to diagnose right-sided cardiomegaly when I see that it's wide on the lateral views, but here's the kicker that I felt has given me a little bit of better, because what I'll do for a lot of cases is I pull up the study and I interpret it before I look at the history, and then I pull up the history. And because we read almost exclusively for specialty clinics, we get a lot of cardiac cases, a lot of cardiac recheck cases. And so it's a game for me. So I pop it up and I go, I wonder if, right? And so I've been able to sort of instantly get this feedback on cardio and what their thoughts are as far as echocardiography, or if the patient's on sildenafil. So I immediately, when I think there's right-sided component, I start going after the medical record, looking for sildenafil or evidence on echo of pulmonary hypertension. But the reverse D has led me astray. Okay. This typically needs to be filled in. So see how this kind of comes around? Usually it needs to drop down. So almost like you would need another triangular focus of cardiac tissue here. So I do think this is getting a little wide, but where I really like to diagnose or get excited about cardiomegaly, right-sided cardiomegaly, is on the right lateral view. The apex, normally it sits right on the sternum. It's in close contact. But with right-sided cardiomegaly, I feel like the apex of the cardiac silhouette swivels a little bit dorsally, and it almost looks like the left lateral view. So the left lateral view, normally the apex swivels. It's just tipped up a little bit dorsally. And when I compare it and the right starts to look like the left, I go, oh boy, I wonder if there's right-sided cardiomegaly. So the take home, in my experience in looking at thousands of these radiographs a year, right-sided cardiomegaly is not that common. I think our ability to diagnose it using survey radiography is not good. And so I think the combination of those, I always kind of give me pause. To further complicate things, and without getting into the pathophysiology, but you can have chronic left-sided heart disease can cause pulmonary hypertension, and with time should increase the right side of the cardiac silhouette. So that's when the cardiac silhouette just sort of gets generally enlarged. You see some left atrium, and then it kind of looks wide, and that may be some degree of chronicity, because as the mitral valve has gone to shit and the fluid refluxes into the mitral valve, it goes into the pulmonic veins, it transports down into the pulmonary capillaries, and then on the flip side, when the pulmonary artery is trying to eject against this increased resistance in the pulmonary capillary bed, you throw in a little bit of vasoconstriction, maybe some remodeling, and you get this sort of pulmonary hypertension that has been created from what we would call a post-capillary etiology, or actually left-sided heart disease. So this particular case, I don't think has right-sided heart disease. Maybe it's getting there, but I don't feel good. I think for me, the salient feature would be this left atrium. So it's hiding a little bit, but it kind of goes up here and then it does that. Okay. So I know that that's the left atrium because I know that's the area to look for the left atrium. I know that I'm not being faked out by a rib, and I see this little bump. The trachea also kind of just floats up a little bit toward the thoracic spine. The VD view, I'm not going to lie to you, I think it's harder, but there is increased opacity here. So as this left atrium gets bigger and you have increased soft tissue, as the X-ray beam comes through the patient, more is just absorbed here, so less hits the detector below, and when less hits the detector, it looks more opaque. So that's when you get the cowboy, cowgirl sign. Okay, so I think this animal has mild, moderate left-sided cardiomegaly. Let's just say you had no idea. You're like, this cardiac silhouette is totally normal. This doesn't bother me. Maybe he's got right-sided heart disease. The animal's tachypnic. So we're here to try to figure out why in the hell the animal's tachypnic, right? So what you should then be able to do is figure out, are the lungs normal or not normal? What I do when I look at the lungs are kind of like the gut in that there's all these variations. They can change. It's such a dynamic organ when you're talking about radiography because the animal could be rotated. He could be breathing in. He could be breathing out. And that dynamic change in the gas is that animal sucks in gas, makes the lungs more black. And you want that blackness. You want that radiolucency because it contrasts with the opacity of thickened airways, pulmonary edema, hemorrhage, and all the things that are opaque. So you want that inspiratory radiograph. So what I do is I first gauge, does it look like the animal's taking a good breath? And Anthony Fischetti, my mentor, used to talk about a piece of pizza. Okay, and so you look right in here, this little triangular area. It's kind of where the accessory lung lobe sits. You want that to be big. I don't know, smaller piece of pizza. He's also rotated. He's not rotated because the nurses are not good. He's rotated because he's trying to die and the doctor's not giving any sedation and they're trying to hustle and they're doing a really good job. And this is a little bit rotated because these spinous processes are just not teardrop shaped. Okay, this is a pretty good red. My guess is they took this first and the dog just got more and more upset. But when you decide, I think the animal's taking a decent breath, which this is a decent breath, and you've convinced yourself, because if the patient is expiratory, it'll make you think that there's something back here, and there's not. So you go, I think there's something here. You flip the dog over on his back, and you go, yeah, there's something here. It's too opaque. You can compare the internal control. Look up here. That lung doesn't look, that's kind of black, and this is just more opaque. And then if you do the zoom out, you go, that looks a little whiter than there. So, okay, so I feel pretty good. And then you go, oh, yeah. There's something there. Okay, so since a lot of you have tuned in before, you've heard me say this, but what you do when you decide that the lungs are not normal is you try to decide where are they not normal predominantly. I love distribution, even more so than sort of patterns in terms of alveolar and interstitial and vascular and bronchial. I like distribution, especially when you're worried about a cardiac problem. Is it worse cranially and ventrally or caudally and dorsally? I think Steve hit it up at 6:39 p.m. Eastern that this is a caudodorsal distribution, and I would agree. Even if there's some infiltrates cranially and ventrally, even if there's some funk up here, even if it's sort of diffuse, if it's worse caudally and dorsally, okay, the next sort of level of the algorithm is you go, is it cardiogenic or is it non-cardiogenic pulmonary edema? And similar to sort of the left-sided, right-sided probabilistic debate, non-cardiogenic pulmonary edema just is not as common as cardiogenic pulmonary edema. So if you see that the cardiac silhouette is enlarged and you have left-sided cardiomegaly and you have a caudodorsal lung pattern, let's not make it more complicated than it is. It's left-sided congestive heart failure. Okay, get them an echo. You could do a loop diuretic like furosemide, IV or IM, right? And the hydrostatic pressure from the overwhelmed left side results in a hydrostatic pressure edema, which is low protein. If you hit the patient with a diuretic, the lymphatics pull that fluid pretty quickly. So you'll actually see fairly quick radiographic improvement and clinical improvement. So you could do if you're not sure, you give them you could do a Lasix trial. If their kidneys aren't trashed, you just hit them with a couple of doses of furosemide. Even if you didn't think that the cardiac silhouette was enlarged, if you ausculta murmur and you have a caudodorsal lung pattern, game on. There's probably some gallbladder debris, or debris, as we call it. Debris, mineral debris. Anybody see anything else? Any other concerns, comments, questions? A little bit of OA in the shoulder joints. Dog's rotated. Left-sided congestive heart failure. Okay, here you go. Geriatric cat, Met check. Met check. They're going to get a dental. 3 views. You got a minute. I can't wait to hear what you have to say about this one. Here we go. Right lateral view. Okay. Here we go. You can keep looking. We had a couple of questions. Doc Allen said, recommend a DV view to look at the lungs if you're not sure. Absolutely. So, and you could do the standard 4 view if you want. I don't, it's not going to, it's just going to make you text nurses angrier, and maybe the animal, but it's going to give you, one, it's going to give you practice comparing VD and DV views. But the DV view, the physics of it, or when you put the animal in sternal, you're going to aerate the caudal and dorsal lung more so than the ventral lung. So this lung is going to be, it's going to be more gas, more black. So if there's more black, it gives you a greater opportunity to see subtle white, the subtle opacity from low-grade edema. So DV view, VD view. You know, you could do the VD view, and then if you're not sure, you just, you know, get the dog back in and try it again. Okay. And then Steve says, or asks, when would the soonest time you would expect radiographic changes once you put the patient on furosemide? Steve, it's been my experience that as soon as you're ready to leave for the day, you would expect to see some improvement and repeat the rads right about the time the clinic closes and everybody wants to go home. Alternatively, 4 to 6 hours. I think it could be fairly quickly. I mean, 6 hours, you should be, it may obviously, it's not going to be better in most cases, but you should, if you compare apples to apples, you throw up the pre and post 6 hour Lasix and you hit them with an appropriate dose, you should see some subtle improvement. Something that's really exudative, hemorrhage, pneumonia, Mets, those piss the lung off. The interstitial lymphatics, they're not picking that up anytime soon, right? Pneumonia, think about it. You're like rechecking rads weeks later. Look at this person. Look at Amelia with this, talking about a hernia. So I like Doc Cruz. I like what you and Dr. Allen are doing, which is describing things, right? Because I think the instinct is to just say, it's a mass, or you know, it's this, or you diagnose it as, you could say it's a hernia, or it's a lung mass, or it's a, you know, it's a primary carcinoma, or it's a Met. And I think getting in the practice of saying, in the caudal thorax, there is a cranially convex mass-like structure. If I measured it, it's probably less than 3 centimeters. So you could say a nodule, but the word mass implies like maybe we should do a little bit more. Yeah. So soft tissue opacity noted in the caudal thorax. I think that's great. Then you go a step further. Okay. The Röntgen signs. Remember, where's my banner for the Röntgen signs? These will get you out of trouble, right? When you don't know what in the world's going on, right? So the location, caudal dorsal thorax, I can see it on the lateral views, but I can't see it. Maybe it's here, but I don't feel good. What I do feel good about saying is I don't really see it. So for this thing to be so obvious on the lateral view, but not to see it on the VD view, to me means it's either dynamic or it's got a midline position, or both, such that it's obscured and it's hard to see. Okay, the next thing is the opacity. Hard to tell sometimes between fat and soft tissue. Hard to tell. You could say that it's soft tissue, or you could try to get away with soft tissue because this is caudal vena cava, and you know there's that soft tissue / fluid, and this structure sort of effaces it. And as a result, you could imply that that's soft tissue or fluid as well. The fact that it effaces it is also an interesting development, because there's something called the plica vena cava, which is a reflection that sits around the caudal vena cava. The accessory lung lobe also envelops the caudal vena cava. So if you have pathology in the accessory lung lobe, depending on its location in the lobe, it can obscure the caudal vena cava. But for me, one of the best signs to look for is that the cranial border you can see, but the caudal border, I mean, the caudal border is hard to see, and it doesn't look like that. And the reason it doesn't look like that is because this margin is outlined by gas, and this margin is not. And so the location, or putting things together by saying, okay, I see this thing in the caudal thorax. It's kind of near the caudal vena cava. I cannot find it on the VD view. The caudal border is indistinct, but the cranial border is distinct. It would suggest that hernia should be very, very, very high on your list. Could it be a lung mass? I think it could. The lung mass just abuts the pleural margin. Could it be a diaphragm mass? Maybe I've seen one of those. So this is what's called a true diaphragmatic hernia. So it's a congenital developmental anomaly. That could be liver, could be some of the biliary system. I think an old mentor of mine put a what's your diagnosis or an imaging diagnosis for a biliary cystadenoma, those cystic liver masses that typically aren't a big deal in cats. It herniated through. So the important thing to do is when you see things like this, don't freak out and euthanize the cat. Clean its teeth. One of the ways that you could diagnose this is you could drop an ultrasound probe and do a subxiphoid approach. So you pop the ultrasound probe here and you fire up here. And you probably see, if you're experienced enough, hit the discontinuity in the diaphragm, but you'll see this structure. And it'll look like liver or a cyst or something like that. The cardiac silhouette. The cardiac silhouette is surrounded by a decent amount of fat. So this right here is all fat. Okay, all this is fat. There's fat here. There's fat kind of creating the border. This is all fat here. So I think this cardiac silhouette is totally normal. I think he's just fat. And again, you want to use some of your internal controls to support your fat comment before you put that in the report and hurt everybody's feelings. Look at this. Look at all this. It's just a ton, right? Maybe this left kidney's kind of small, kind of skimpy, but boy, that looks more normal on the lateral views. So true diaphragmatic hernia, okay? Case is cool because you use these physics principles, these imaging principles, these Röntgen signs to try to figure out, what is this? Do I really need to freak out? Do I really need to worry about it? Maybe I don't believe it. I don't believe it. Yeah, I think the fat is, if you kind of, you can see this. You can see this. What do we think this is? This is the aortic arch, right? We expect the aortic arch to come out here. It kind of pops up here and it goes down there. And the aortic arch is fluid/soft tissue. So if I can see this border, that's because something that's not fluid/soft tissue is adjacent to it. Okay, well, it's this opacity. Well, if this opacity is more opaque than this opacity, I know this opacity is gas, so shit, that's got to be fat. And if that's fat, that's making me think that this whole thing is like a wide cardiac silhouette. That's probably fat too, right there. All right. I'm going to show you this. I don't want to go through the whole case, but I kind of wanted to show you. This doesn't necessarily have the tipped sternum, but this cardiac silhouette's getting kind of wide. It's getting kind of wide. Okay, I would be excited to start talking about the possibility of, I think this animal has right-sided cardiomegaly. And I think this animal has a caudodorsal lung pattern. And I think this physics principle on this is what we can use with the last hernia. This is very clearly delineated, but I don't really see, it looks like it's just floating on the chest. And the reason is because this is surrounded by gas and this is not. And this is the gas from the skin. So it's attached to the skin here somewhere. And then here it's surrounded by gas. So this is a body wall mass. Where are you? You're right there. Cool. So I think this is a right-sided cardiomegaly. I think it's caudodorsal lung pattern. It's an old dog with a bad back. Go softly. Take it easy. Some horrible shoulders. Caudodorsal lung pattern. Maybe a little bit of left-sided cardiomegaly, but I think predominantly right-sided cardiomegaly. Have you guys heard of sildenafil responsive pulmonary infiltrates? These animals that get edema caudodorsally, like a left-sided heart failure patient, but it's actually from a chronic state of pulmonary hypertension. All right, here we go. I think maybe we're going to do three views, okay? Wretching. We're not doing that view. Do this view. Let's see here. So first thing to notice on the VD view is we want to use the anatomy, not the markers, right? Splenic head, fundus, duodenum. So the right is mislabeled. Okay, when you get these radiographs that are poorly centered, right? This looks to be centered on the sort of liver diaphragm area, and so you get everything. And all these do is they just take me a lot longer to read to help. But when you get this, if this is what you're getting in your clinic and you don't want to go through the training or you have to turn over all the things, just focus on one cavity at a time. So I'm just focused on the chest, and I just sort of ignore the abdomen. And then once I'm done concluding in my mind about the chest, I then look at the abdomen. And I sort of do that sequentially so I don't get overwhelmed. This is also poorly positioned. It's centered right here. It should be centered on the heart, okay? So increased lung opacity caudal-dorsally. I'm glad that you said that because I think one of the things that I'm glad that you said that because then we can use the Röntgen signs to come back maybe one step before we say the word lung. So what I would do in this particular case is I would say that there's an increased opacity in the caudal dorsal thorax. So I go from sort of general, and then with confidence, I get more and more and more specific. And as you get more and more specific related to location, you can then refine the differential. So So Steve's talking about the esophagus. Amelia's talking about the esophagus. Went so far as to say there's a foreign material in the stomach and the esophagus. And so I think what I would do in this particular case is you could say there's something abnormal in the caudal and dorsal chest. And then when I flip the dog over, I'm having a hard time seeing it in the right caudal lung lobe and a hard time seeing it in the left caudal lung lobe. And I'm not used to looking at these, but man, there's something that just looks more opaque here. But if you can't get your head to commit to this, you could get your head to commit to there was something here, but where did it go? So once you do that, once it's not pushed off into either lung, Doc Cruz, you got to then go, is it possible it's midline? Is it possible it's mediastinal? Okay. And then with the mediastinal, you got to keep thinking about things like the esophagus, the esophagus. Okay. So increased opacity in the caudal dorsal thorax. I don't know where it is. You're like, I don't know, but flip it over. It's not in the lung. So maybe I need to be more broad. Could be in the esophagus. Yeah. So this is looking a little bit more mineral opaque. But if you weren't convinced that it's an esophageal foreign body, you get the dog back, you put him on the table, you put a quarter-sized thing of barium paste on the roof of his mouth, and then fire off orthogonal views of ED and a lateral. And this thing is going to be outlined by barium. And the internist, whoever's scoping or whatever, is going to be pissed, but you needed to diagnose it first. So that was the main point of this one. Is there a dynamic pectus excavatum? I don't think that there's a pectus excavatum. I think the animal is markedly rotated and all bets are off. That looks pretty straight to me there. He's very rotated here. Spinous processes here, and I don't really see marked deviation of the sternum. Okay, everybody got that? Pectus excavatum is a defect. There's pectus excavatum and there's pectus carinatum, which is the opposite. So a pectus excavatum would be an excavation of the sternum or the chest. And so usually the sternum comes along like this and then it just collapses in. And a pectus carinatum would be like, I think they call it a pigeon chest in people. So it comes out and it dips out. So it's just a malformation. Yeah, and so you're always talking about a dynamic one. So it's been reported, and I've seen it. I've seen it in cats when there's an upper airway obstruction and they're sucking against a closed glottis and they draw in that negative air. It will cause the more free-floating part of the sternum to sort of move up and down a little bit. And so it could be a telltale sign that you should be looking further up, like a polyp in a cat's nasopharynx or something like that. But I think the airway's fine in this particular patient. All right, let's do one more. Let's do one more, and then I got to go eat dinner. Ooh, boy. Here we go. So there's 1, 2, 4, 5. So there's 5, but I'm going to give you the skull. Hold on. There's a radiolucent margination of one of the cranial lung lobes on the cranial thorax left lateral view. That is that normal? Let me get this. I think this is a normal lobe margin, and it may be in an unusual position because the animal's rotated. So I think the other possibility, but I'm not feeling great about it, is that the craniothoracic esophagus could have fluid and gas in it, but I'm not. Yeah, that doesn't. I don't think that that's esophagus because it rounds up like this. I don't feel good that that's esophagus. I think that's probably the lung. I think you're right. And on this view, I don't really see any abnormalities in either of the cranial or the caudal subsegment of the lung lobe. Remember, he's mislabeled. So I'm wondering if we're seeing some of that from rotation of the patient. Sometimes they'll have what's called also plate-like atelectasis, but these tend to be oblique soft tissue bands because they think sometimes these animals have these fissures that aren't in the expected spot. So sometimes you can get these little things. I don't think it's a bulla. I don't think it's pathology. This is on the left lateral view, and when it's on the left lateral view, the dependent lung rises dorsally. So that's probably the left cranial lung lobe, but I agree it's a little bit odd in shape. But I don't think that it is I don't think it's pathology. My guess is it may be that there's an extra fissure in there, and with rotation, it's making it look unusual because this looks totally normal. All right. I don't know if that helps. Skull rads. I'm going to do just two views, okay? Animals drooling. This is a geriatric gatito. Okay, so we got a left lateral view. I'm going to flip this. Okay, this is how I look at skull rads, like this. And then I'm going to do a little bit of rotation. Here we go. All right. Drooling cat. Yeah, I'm going to give you a little a pointer to help. You guys aren't terrible. Look at this. Seems to be missing some of his left mandible. Oh man. All right. So I'm gonna just have to break out some hard cases, some difficult cases. So here's the first thing that I'll do, okay, to help you. So you're right. There is an aggressive bone lesion in the rostral aspect of the left mandible. So here's what I would do with the here's what I would do for the skull rads. Okay. The skull radiograph that is the best shot is the DV view. Unless you've got a completely destroyed mandible through trauma or completely obliterated with lysis, the mandible will act as sort of a level. And so you can gently sort of push the animal's head into the table so that you can get that almost perfect symmetry. Because of all of the superimposition and the complex anatomy of the head, you really want to depend on the ability to compare left and right. So the round dorsal aspect of the calvarium, even if you've got a pretty cooperative patient, you'll get the rotation. So I would encourage you to try DV views. That's going to be a huge help. Okay. So first thing I do is I look at the tympanic cavities. The bullae right here, they should be paper thin in a cat. So these are paper thin and they look symmetric. Okay. The next is the TMJ, or the temporomandibular joints. Here's one right here, and here's the other one right here. So those are normal. I also look at the coronoid processes. Coronoid process, make sure they're not like outside the zygomatic arch, like he's luxated something. I look at the zygomatic arches, and the maxillary bone right here for evidence of lysis. I kind of zoom out too. Don't forget the soft tissues. So this is the rostral aspect of the globe, and that doesn't really look like there's any abnormality there. But so it looks like Dr. Miller's got her connections up. Here's what I do for the mandible, and if you get a DV view and it's pretty straight, all you do is you go from here and you just follow the inner cortex. So all I do is I just go all the way down, all the way down. You can zoom in if you want, don't zoom in too much, and then the mandibular symphysis is going to be right in here. There's a canine. So that mandible, the inner cortex of the mandible, it should go all the way down, okay? You pop over here and you go like this, inner cortex. It's just gone. We can talk that cortex is sort of normal and thick, and that this cortex is probably osteopenic. But this cortex, you follow it down. I can follow a cortex, and then, boy, it just is not really here. I think this is a DV view because the clinic tends to do DV views. Oh, and it says DV view. Yeah, Watson, so you can see it. Nice, dude. That's all you do. That's all you do. You get a DV view. Yes, you get the laterals. Yes, you can get the obliques. Yes, you can get the rostrocaudals. You can get all the fancy ones. But I feel like at the end of the day, get a DV skull rad if the animal will permit and the mandible is going to permit. And if you just follow this cortex on each side, it's like trying to follow the pelvis. You know, if you were taught to do that on a VD pelvic rad for trauma, you just want to follow it around. And this thing should go all the way down, and it doesn't. So it's blown out right here. And there's no dental disease that's going to do that. And there's obviously chronicity because this bone is sort of, the cortex is thinning here. So that's probably, it could be a squame, it could be a primary bone tumor. There's not a lot of periosteal reaction, but it could be a primary bone tumor, it could be a squamous cell carcinoma, things like that. Mycotic osteomyelitis, sure. Bacterial osteomyelitis. I feel like when I see bacterial osteomyelitis, I feel like squamous cell carcinoma just does this. Things just disappear. Bacterial osteomyelitis, there's raging swelling, there's really bad periosteal reaction, there's mixed like sclerosis and periosteal reaction. It's just this haphazard awfulness. But cats that have mandibles that disappear like that, you should be worried about squam. All right. The temporomandibular joints on the lateral view can be tough if the markings aren't correct and the positioning's not correct. So here's one that's right here. And then here's one that's right in here. And there's a tympanic cavity, and there's a tympanic cavity. So I like the idea of if you jump into Thrall's textbook, I like what they do, which is when you do an oblique view, I like the marker up top to be the more dorsal. So if you have the patient face down on the right, you're in right lateral recumbency, and you tip the animal so that the left side is more dorsal, I like the idea of putting the Mitchell marker left up top and right down below. And then doing that for the other side, trying to get, if you can, a perfectly positioned straight lateral, and then a DV view. But I like the idea of, because I've been surprised by the difficulty of using magnification. Usually with a limb, you can use magnification to say, oh, that's the left, oh, that's the right, and determining laterality with magnification. I've been surprised at sometimes how challenging that could be with skull radiography, at least in my experience. And so I like the idea of when you tip the patient off to have two different markers, and whichever one is dorsal, whichever side is rocked up dorsally, put that marker up top. So up here would be the right, and this one would be the left. And then that would help you tell which mandible that is and which mandible that is, because this is a normal right mandible. Okay. And this one is, you can kind of see it, it's the absent left mandible. And to me, when I look at these, I go, oh, well, this one's more clear. And this one looks fuzzier and, more magnified. So maybe it's a right lateral. So it's tough. I mean, I like the idea of saying, of using that designation. And that designation will help you with the temporal mandibular joints as well. It'll help you determine which one's the TMJ. But that's a TMJ right there, and it's hiding over here. You can see it really well right here. Okay. Okay, everybody, if you're not getting, I'm using a new email product. My old emails were getting bounced. There's like, over the course of these 9 weeks, there's been 750 people that have variously registered. And I tried to send an email, and that didn't go well. So a lot of you weren't getting the emails. So now I've got a new email chain going, and these should be getting to you. So if you're not getting them, email me at info. See if I got a banner. info@parallax.vet. I'll type it in the chat. But email me, and I'll get you on it, because what I'm going to do is I'm going to have the link and the date and times and all that, and hopefully make it a little bit easier. Because I know info@parallax.vet. That'll come straight to me. Okay, so do that. But you should be, if you register, I'm just grabbing the registration emails, dumping them into the email server, and just sending them back to you. So you should be getting them. But I hope you guys have a good week. Send me some cases if you want. We can talk about them next week. We'll see you next Monday. Hope you guys have a good week, and take care.